we will be talking on a PCOS. PCOS is a huge subject. It starts from an adolescent and it remains till the end of a life of that lady. So we have different problems which we face in adolescent. We face in adolescent age group. We face the problem in reproductive age group. We also face the problem perimenopausal prep and then the menopausal. So let's see how we can go ahead with it. Allow me to share my screen today. Let's talk about. We all should know PCOS is the most common condition in this age group. Though we precisely it is 8 to 13%, in around 10% of the group, it affects. In 10% of the reproductive age group, you can have this problem happening. And how do we tackle? Let me go with it. Anytime you put in a Google also, you will find 1,400. I've just put the type PCOS and 1,400 plus references come. So it's a huge topic. It's a public health issue. It's a woman health issue, which affects the reproductive, metabolic problem, or the psychological also, obviously, because of the acne, hirsutism, alopecia, obesity, it becomes a psychologically, any lady feel depressed. Now, what is the pathophysiology? It is the interaction of three factors. They interact and work with it. The three important tissue which happens here is one, excess androgen, hyperandrogenemia, adipose tissue dysfunction, and insulin resistance. And this is a crook of all the problems which happens, whether it is an endocrinological, metabolic, or reproductive related problem. Now, what happens when there is an insulin resistance? There will be hyperinsulinemia. Because of the resistance, body doesn't recognize, and the more and more insulin on demand gets secreted. Now, whenever there is a hyperinsulinemia, one thing happens with the liver is it decreases the sex hormone binding globulin. Now, if the sex hormone binding globulin is not there, what is going to happen? The testosterone, which is getting produced, remains free. And this causes hyperandrogenemia and the symptoms and signs related to it. At the same time, there is an increased production of ovarian androgens also. And that also will give even if there is a production, since there is decreased SHBG, there will be increased androgen level. Because of all these, there is impaired LH secretion, oligo-ovulation, and that will cause a PCOS. So PCOS affects at all the body organ level, mainly hyperinsulinemia, decrease in a SHBG, increased testosterone. There is in multiple follicle, that is increase in a AMH value. At the same time, increase in a GnRH pulsality increase and increase in the LH. Again, this is more or less the same I tried to explain to you. Now, there are 2-3 important things one has to understand. There are certain newer idiopathogenesis which are coming, and genome is the one which has come up now. The genome-wide association, they say there is a genetic predisposition for the polycystic ovaries. And there are certain types of gene where if they are present in PCOS patient, they will give them metabolic syndrome and insulin resistance. Now, why we should be knowing? Because in a PCOS, there is so much variety you get. Forget only lean PCOS and obese PCOS. Some obese PCOS, they may not have any problem. They may have still regular cycle. Only their ovaries, they are bulky, more than 20 follicles, and they have a hyperandrogenism. All clinical picture. But otherwise, their cycle can be regular. On the other side, you will have an obese lady with diabetes, with all other problems reaching up to this. Apart from a subfertility, many other problems. So why we have a wide variety? All this is because the PCOS phenotype, it changes. Now, most importantly is 70% of the affected women remain undiagnosed, because there are many challenges in diagnosis and there are many controversies with it. Now, one thing I'd like to tell you all, that any obese lady coming to the cabin and says, I have a fertility issue or irregular menses, blindly get labeled as a PCOS patient. Sometimes at 35, when I see their ovaries, hardly 4 or 5 follicles scattered throughout the ovary, no hyperandrogenemia, irregular cycle, the patient was labeled polycystic ovaries, irrespective of anything. Sometimes, so it's very important that you do the sonography. Put the transvaginal probe in a reproductive age group to find out, are these PCOS or is it a decreasing ovarian reserve? And that is caused poor AMH, whether she is having premature ovarian failure. Obesity is just the one factor. So you need to be very clear about it. So diverse phenotype and different characteristics puts us challenges. But once, remember, any adolescent, you are labeling it, it becomes a stuck in her mind. And whole her life, she will be carrying that stigma with her. I'm PCOS, I'm PCOS. They come, some women call it PCOS. I don't even understand what is PCOS. So for a PCOS, they label it that. So with PCOS, there is a lot of heterogeneity, and more or less it becomes a diagnosis of exclusion. Patient has a thyroid disorder with obesity, unnecessary, she gets labeled with the PCOS. So we have to rule out. Prolactin disorder, hyperprolactinemia, again unnecessarily get labeled. Congenital adrenal hyperplasia, giving a higher testosterone value, and all hyperandrogenic symptoms like hirsutism, alopecia, acne, and probably unnecessary get labeled. So all these criteria should be labeled. More than a polycystic, sometimes I call it as a polycontroversial ovarian syndrome, because it's highly controversial from everything, from the diagnosis to various management. And today in 40 minutes, we'll see that. This heterogeneous, different genetic variants leads to different phenotypes, I already told. Now there is a guideline to the guidelines. This is very funny. In early 1990s, we used to use National Institute of Health guidelines. We all obviously knew that it has many fallacies. Only oligo-ovulation or hyperandrogenism was only called. Then came the Rotterdam criteria in 2003. Out of the 3 criteria, which they said, every one of us know, either the ultrasonography or androgenic, maybe upserium, or the patient have acne and hirsutism, or if a patient polycystic ovaries on a sonography and an ovulation. Any 2 signs positive, we used to label it as, but it also has many fallacies. And that is why then the further modifications happen. And then there came the Thessaloniki ISHRE ASRM, which happened in 2008, but they did not become more famous. But in 2012, ISHRE ASRM and everyone came together and they labeled these criteria. So these became more or less now in 2018, ISHRE ASRM guidelines. They came into the existence. While those who were diagnosed with Rotterdam, 2 of the 3 criteria of oligo or anovulation, hyperandrogenism, either biochemical or clinical, and polycystic ovaries. Now, there are many fallacies in this. What was the basic thing is and also this is a ISHRE ASRM guideline. Now, this ISHRE ASRM guideline, they have evolved beautifully. Why we are accepting them? They were 70 world leaders from 37 societies came together and they started working and they came out. And they labeled certain problems which we were facing. One is, we say, these patients have a ovulatory dysfunction. Now, ovulatory dysfunction, sometimes there can be still a regular menstrual cycle in a PCOS, and still Rotterdam can call it as a PCOS. So whether there are characteristics, whether you need to do the hormone assays, all is important. Second important point is irregular cycle and ovulatory dysfunction can be a normal component at the pubertal and the menopausal transition. So this is patient coming to me started menarche at 24 and she comes to me at 25. Am I supposed to think that this is PCOS, or am I supposed to work up for PCOS, or am I supposed to just counsel them that this is just the menarche you started and that is why your cycles are irregular? So in adolescent, at what time after the onset of menarche, we should say the irregular cycles are not physiological because of the puberty or adolescent age group, it's pathological. This is a beautiful in this 2018 classification. They spoke very clearly that 1 year post menarche, it is normal to have an irregular cycle because of the pubertal transition. So it is only 1 year. More than 1 year, but less than 3 years post-menarche, we can consider less than 21 or more than 45 days as irregular cycles. But more than 3 years post-menarche, we should label that anyone having less than 8 cycles per year, more than 35 days, still we should call it as an irregular cycle. So when irregular menstrual cycles are present as a diagnosis of PCOS, should be considered, and then we should assess. So if the lady comes at 28 and she says, I have irregular cycles, I started my menses at 12 age group and my cycles comes every 40 days, I should start thinking whether she's PCOS and I should definitely evaluate. Now, sometimes they may not be fitting to your diagnostic criteria, but they do have certain features, though we cannot label it as a PCOS, so we call them as an increased risk. You don't meet the diagnostic criteria, but you are probably at increased risk, and we should be advising them to reassess themselves 8 years post-menarche. Now, why this sonography and all these is a problem? Remember, younger patient may have follicles multicystic. They may have 20, 25 follicles in their sonography. Now, you can mislead them. And that's why sonography may not be considered just as a diagnostic criteria. So this is another question. So we all understood when we call it as irregular menses, first 1 year, we will take normal, but anytime after the 3 years of post-menarche, more than 35 days cycle, please consider that as an irregular cycle. Now, in which woman this suspected with PCOS, what is the most effective measure to diagnose the PCOS-related biochemical hyperandrogenism? How can I diagnose? One, your comprehensive history. Then comes your physical examination. Then the symptoms, signs, because nowadays people, they do all the cosmetic surgery, and when they come, they may not have a hirsutism. They may not have the excessive mustache or the growth. So you need to see also their skin texture. It's little thickened skin. The acne will be there, and she will say, I have an excessive hair fall happening. This all is important, but at the same time, remember, there is a confounding factors. Ethnicity. Sometimes there may be a normal in their certain ethnic group, these characters. And in excessive weight itself may be a normal. So if you don't have those clinical pictures, then you have to do the biochemical. Now, in biochemical, always write free testosterone and free androgen index. And if this is normal, then you go for an androstenedione and dehydroepiandrosterone sulfate. Now, why this is important? Because you cannot keep on putting the patients on so much work. But many a times, my patient, if they are staying outside, they may not be possible to come again. I advise them free testosterone, androstenedione, and DHEAS. I advise all the 3 tests because they cannot keep on coming again and again. But one thing very important when you are advising the androgen test, ask her by chance, any other gynecologist has put up for a regularization of the cycle on OC pills, or she's sexually active and taking OC pills. Why this is important? Because if she's taking OC pills, then your biochemical assessment may get hampered. You need to stop this for at least 3 months or maybe a longer, and then only you should be advising this androgen test. So friends, this is very important. As soon as patient comes, don't start investigating without going through the detailed history. Now, when is the ultrasound indicated to diagnose? On one way, I say in young adolescent, you may get multicystic and your sonologist labels it as a polycystic ovaries. When do I advise the patient? Am I supposed to do in a young patient unnecessary? So suppose if she has a cycles more than 35 days, she has a clear-cut hirsutism and she has a alopecia and she has a acne at 18-19 age group. If she is not sexually active, I may not advise her sonography. You just do her hormone test and you confirm with your history of irregular cycle or anovulation. But to decide the phenotype, you might advise the patient to do the sonography. So what are the most effective criteria? So ultrasonography should not be used for the diagnosis of PCOS in those with the gynecological age less than 8 years after menarche, because there is a high incidence of multifollicular ovaries in very young age in 20s. And that's why ultrasonography should not be, as I told you. You can defer the ultrasonography sometimes if they are sexually active to decide the individual character. You can do the sonography. Now, previously, we used to call lesser number of follicles. Now, the follicle number has to be 20. From 12, it has jumped to 20. So 20 peripheral chain of a follicle is very important. Or you consider the ovarian volume of more than 10 cc. But that ovary should not have corpus luteum or dominant follicle or any other, because it itself can increase the volume. Usually, transvaginal sonography is preferred than the transabdominal sonography, because in transabdominal, sometimes, especially in obese, they cannot see all these peripheral chain of a follicle. And one step ahead, I'm just giving you a practical tip. If your patient is of a reproductive age group, 32, 33, you are going to take her for ART for some reason, then in the stroma, which is there, always have a habit of checking the vascularity of the soma. If the vascularity is excellent, she will respond. But she's 35, there are peripheral chain, but the vascularity is not there. Believe me, these patients don't respond as we expect. So always have a habit of checking little more than it is. So only 12 follicles or measuring between 2 to 9 mm is now outdated. And now, according to 2018 newer classification, we consider more than 20 follicle or the ovarian volume more than 10 ml. This is very, very important. Ultrasonography should not be used, as I told you again, in an immediate post-menarche period in an unmarried girl with the irregular cycles, hyperandrogenism. But if you are doing it, sometimes it may be to complete your PCOS phenotype. Otherwise, please, in young patients, don't do the sonography. Is AMH effective for diagnosis of PCOS? Again, in a younger patient, you may have otherwise also high AMH. So AMH, what does it does? It is depends upon it is solely secreted by the granulosa cells of a preantral and smaller antral follicle. So anyone who have an increased count will have increased AMH level. They are higher in a PCOS than normal ovulatory, I do understand, but they should not be used as an alternative for detection of a PCOM or as a single test to diagnose the PCOS. AMH alone cannot be taken. So where are the controversies? And let us go with one by one on all. We have to understand in a PCOS, there is an ethnic variability. Which contraceptive to use, which stimulation protocol to use, which gonadotrophins to be used, when to do the drilling, and what is the IVF protocol. Let's go 2 minutes, 5 minutes for each. Ethnicity. There is evidence that ethnic and geographic variations are present. What are these? The ethnic differences appear to related primarily to the skin manifestation and metabolic features. And there are many studies, if you go from last 2 decades, there are n number of publications which has proven that the ethnicity and the geographical variations between the Asians, Africans, and Caucasians. In Indian PCOS, and non-obese reference subjects had a higher insulin responses after a glucose tolerance test than did the white subject. Higher prevalence of PCOS reported in a South Asian than the white Caucasian. South Asians present and seek treatment of PCOS at a younger age than the white Caucasian and have a more severe symptoms, high fasting insulin concentration, and low insulin sensitivity than white Caucasian. So you have to understand that in Caucasians, there is a relatively mild phenotype. Higher BMI in Caucasian, especially in North American and Australian, among the all. More severe hirsutism you will find in Middle Eastern, Hispanic, and Mediterranean women. Central obesity, insulin resistance, diabetes, metabolic syndromes, and acanthosis nigricans, they all are found in Southeast Asian mainly. Low BMI and mild hirsutism in East Asian, while high BMI and metabolic features, along with these all acanthosis nigricans and metabolic risk is also seen in Africans. So in Asian, remember, PCOS can be seen at earlier age, more prevalent than the Western. Metabolic syndrome will be more severe, and there may be a cultural differences. Now, this is very interesting study. There is a poor prognosis in IVF in Indian women compared to Caucasian. This is a beautiful study where they have taken 2 years nearly to do these studies. And what they have done is 145 around Caucasians and 80 Indians with the blastocyst transfer who have undergone. And they just did the blastocyst study, and they found that despite the young age and similar embryo quality, the age group they match, the embryo quality they match, Indians have low birth rate than the Caucasian. In this preliminary study, poor prognosis after IVF for Indian ethnicity persisted despite limiting analysis to the patient with high quality embryo transfer. And that's where we have to be little careful with the PCOS. Now, when we talk about PCOS treatment, I can finish up in one slide. If the patient is for only irregular menses, unmarried, you just give her OC pills. You decrease her LH, you decrease the hyperandrogenism, and the things can be easy. But remember, the patient has to be known that the moment she stops the OC pill, her cycles will become again back to irregular. Also, because she's taking OC pills, because her menses are coming regular, she doesn't bother to take much of the exercises. So I'm coming to my point, how I manage there. But OC pills. Now, if hyperinsulinemia, just give a metformin, which will reduce the insulin resistance, and it will increase the sex hormone binding globulins, and it will correct the metabolic problem. If the patient has a hyperandrogenism and increased free testosterone, and that's why the skin problems, then you can give just the anti-androgens. So in these three things, I can combine and I can finish, but let's go more important is a lifestyle modification. So how do I treat these patients with irregular cycle? Lifestyle modification is a mandatory. Unless they have an effective weight loss, they cannot have improvement in their metabolic, reproductive, fertility, quality of life, emotional well-being, everything. Rate of weight gain and prevalence of excess weight are increased in adolescent. Sedentary, the way they are eating the food, everything is bothering. But insulin resistance is seen even in lean PCOS. It's not only in obese PCOS, though the incidence is marginally less. Most important thing is achievable goal, like 5 to 10% of weight loss, also gives us a significant improvement. So if the patient comes to me for a preconceptional counseling, and if she tells me that I'm obese, I'm labeled as PCOS, I want to plan pregnancy, and that's why I came. I will first is confirm by sonography. Then I will do her hormone test. And then what I will do is I'll put these patients, if they have an insulin resistance, on metformin. I will make them do weight loss. I'm not putting metformin for an ovulation induction. I'm using metformin to decrease the insulin resistance, to increase her sex hormone binding globulin, decrease the androgen side effects. But at the same time, I tell her 6 months, go and do your sustained weight loss. That's very important. When she will do the weight loss, automatically everything will help. Believe me, if they take seriously and if other parameters are normal, the patient will come back with the pregnancy to you. So very important, you spend at least 10 minutes in explaining specific, measurable, smart, we all say smart goal, achievable, realistic, timely. Because if you tell 100 kg patient, go and reduce 40 kg, she's not going to come to you again. So you need to be realistic also. 10% body mass itself is also enough. And what usually I say is you have a calorie-less diet, calorie deficit, energy deficit diet. If your body requirement is 1,500, you take 750 calories a day, or maybe 1,000 calories, and improve with your walking. 10,000 steps a day walk is a mandatory for them. Now, I read this I never used to like to tell ketogenic diet or drastic weight loss to my patient. I used to tell them 1 kg per week. Go on a sustained by 3 to 4 kg in a month. And in 6 months, achieve around 15 to 20 kg. But in June 2022, I found out this interesting publication by Italian group. What they did is they put the patient on very low calorie ketogenic diet and a standard low calorie diet. And they studied body weight, insulin resistance, menstrual cycle, ovulation, and everything. And what they found was there was a drastic decrease. P-value was significantly significant. There was a drastic decrease in a weight and BMI and the waist circumference fat mass. They found 12 kgs weight loss compared to 3.7 kg weight loss in other. And they found significant improvement in all the parameters. Hyperandrogenism disappeared. Insulin resistance disappeared. They found beautiful results with very low calorie ketogenic diet. So maybe let's try sometimes in our patients too. What they found was adipose tissue dysfunction is the main cause that causes oxidative stress and the ovarian hypotoxicity. So if they decrease this adipose tissue dysfunction, if they decrease the adipose tissue, the body mass completely, they will definitely have an improvement in ovarian hypotoxicity also, decrease in the androgenism, and improve in a ovulation function. So the very low calorie ketogenic diet they suggested, which gave a significant weight loss. They promoted loss of abdominal and visceral fat also. There was a decrease in the lipotoxicity and improve in a high insulin resistance. So all this was very, very important. They also found that it helped in type 2 diabetes and non-alcoholic fatty liver diseases. So they advise ketogenic diet, but believe me, it is only the one study. If they do the ketogenic diet and if they leave that low volume, so if they are going to do, if I have to think of doing this, what I will do is very low ketogenic, maybe for 8 weeks. But after that, after having a 12 kg weight loss, they should go on a low calorie diet and continue their walking, exercise, the smart, what we say, smart goal. Otherwise, they will bounce back with their all PCOS features. 10,000 steps daily is very ideal. Now, if the patient is not in a reproductive age group or planning pregnancy, adolescent age group, oral contraceptive, which is the contraceptive pill, if at all you want to use, it is safe. Remember, any pill will work. So try to use lowest effective estrogen dose. And that's what is important, that you have a lowest effective, because it will cause a regularization. So CPA plus ethinyl estradiol combination will have better, because there is highest rise in a SHBG and decreases the androgenicity drastically. and you can use those. Who do not desire, the first line of treatment becomes a OCP. Now here, I'm going to tell you what I do in my practice, because you have several patients who says, मैं एक gynecologist के पास गई थी, उन्होंने मुझे 2 साल दिया, मैं लिया, everything was fine, I stopped, it became irregular, then I took, it became regular, I stopped, it became irregular. Why she is with you? Because she is not happy with your 21 days pill for a long. Try to imagine young girls taking this pill. So what I tell them is, why I need to regularize when you are unmarried. That is to avoid hyperestrogenic effect on endometrium for a long. You should know from menarche only till the menopause, you should have at least 6 to 8 cycles per year. And that's where, because I tell them, I give them a menstrual calendar. And I tell them, start doing your diet, exercise, and everything. 10% weight loss, you have it, your menses will become regular. And if they really take it seriously, they find in the menstrual calendar that their menses have started coming regular. That's fantastic. That's one way to motivate them and prove them that 10% of a weight loss will help them. If you don't do that, and if you put them only on a OC pill, no young girl will go and do the amount of exercises they are supposed to do. They will still keep on eating pizzas and burgers and parties. So I tell them, you keep a menstrual calendar, wait for 5 to 6 weeks for the menses to happen. If you are reducing your weight, your menses will happen. And if you're not, then I give them 5 days progesterone pessary with them. They can take those 5 days norethistron, progesterone, and they get the withdrawal bleeding. So 1 cycle in 2 months, 6 cycles till you are in your menarche phase, in an adolescent phase, shedding of the lining every 2 monthly is acceptable. And you will start getting regular cycles once you get the weight loss. So those patients, instead of putting just on a OC pill, if they don't have much of a hirsutism or acne problem, they don't want to work on their hyperandrogenic condition, they just want to regularize their cycle, maybe, and especially if they are obese, I will like them to go for a diet, exercise, and weight loss program, keep a menstrual calendar, and take a progesterone withdrawal every 5 to 6 weeks, then having a 21 days OCP. But if they have a hyperandrogenic features, then you need to put them OC pills to decrease the LH and to decrease the androgens. So you need to, every patient has a different phenotype. You have to sit and work out. Some girls are educated, they understand, they're so conscious about their health that they will do everything possible without medicine. These are the patients you should explain them with diet and exercises. OC pill will help us to reduce the even adrenal production of androgens. So this is very important. Now, is there any other combination I can use with OC pills? Can I give a metformin to this? It can be considered for a management of a metabolic features where OC pills and life changes are not achieving the goals we want. She may be fertile. She might have got 1 baby. Now she has irregular cycles. And alone OC pills, her diabetes, anything is not coming under control. You are justified to do that. While in adolescent, where BMI is more than 25, OC pills alone and diet exercise is not giving the desired goal, then you can give a metformin, which will help them in all the ways. Most beneficial in a high metabolic risk group. Diabetics risk factor hai, high incidence in the family, impaired glucose tolerance gram, or they are in a high risk ethnic groups. You still justified to do the metformin. But when metformin is prescribed, you have to explain the patient about the GI doses. Always start with low dose, maybe one tablet a week, once a day for a week, then twice a day for a week, and then she goes stepwise on 3 tablets a day. Use one thing very important. Metformin use appears safe long-term, but it may be associated with low vitamin B12 level. So if your patient is vegetarian, who is bound to have a low B12, and on the top of that, you are putting her on metformin, please ensure that you are checking her B12 levels little more regularly. Inositol. Inositol should currently be considered as experimental, but because as of now, no evidence is saying that inositol will work. But remember one thing, there are many emerging evidences which are coming, which highlights the positive results of inositol. And frankly speaking, for last 1 year, I became a fan of inositol in my reproductive clinical practice for my infertility patient. And this is the way myoinositol. So we got a combination of myoinositol and dichloroinositol, and we always use that. That has to be used in 1:40 combination. Then it will give you desired effect and it will work. So inositol in PCOS, as I told you, maybe improves metabolic, hormonal, and reproductive. These are the publications which are coming in last 2020, and I'm sure over 3 to 4 years, it may become evidence-based. What about the anti-androgens? Yes, they block the effect of androgen, the pilosebaceous unit, or in the hair follicle, and you can be used spironolactone or the cyproterone acetate combination OC pills. You can use them because the young patient, especially with the hirsutism and acne, they may have a social and behavioral problem, and that's why you can be combining them. But you should always tell them, reduce your weight. Weight loss itself will improve your androgen concentration in the body, because alone OC pill will not work. Should women with the PCOS undergo preconceptional evaluation for where risk factors may be adversely? Yes, definitely. Why? Because they may be diabetic, they may be very overweight, there may be associated blood pressure. Unless all these things become normal, you cannot ask her to be conceived. Otherwise, she will land up in 3rd trimester with PIH and diabetes and all other problems. So, very important that these patients reduce. Now, let's come for the infertility, simple oral ovulation. We all know the clomiphene was the preferred drug, but now later evidences are allowing that letrozole can replace the clomiphene. Letrozole for 2 decades. Of course, it is not the many countries the labeled drug for ovulation induction. In India, with difficulty, we got the permission back. But letrozole was first proven non-inferior to CC. Any drug comes, they first have to prove their non-inferiority, and letrozole has proved it. Second important thing is latest guidelines and meta-analysis, they allow us to label letrozole as a first line of treatment. So what should be the principle? What is the basic difference between the clomiphene and letrozole? Just understand this basic. Clomiphene goes and work on the hypothalamo-pituitary. It depletes the estrogen receptors in this. Because estrogen receptors got depleted, the FSH, because pituitary is not getting any negative feedback, that's why the FSH starts releasing, and this FSH will give an increase in this. Now, when the dominant follicle will start coming, then the estrogen level, because initially they are low, they will inhibit, and then later, but even if there is more follicle, what happens with them is, because the receptor got depleted, the pituitary doesn't sensitize. So even if body E2 level are rising, the negative feedback doesn't happen and FSH keeps on pouring. So it is the central mechanism. What happens with letrozole? There is no receptor depletion. It reduces the negative feedback due to low estrogen levels and lead to rise in an endogenous gonadotrophin secretion, because it is aromatase inhibitor. So there is no conversion of androgens to the estrogen. So estrogen is not there. And that's why the pituitary is not sensing that. And that's why FSH comes. The moment FSH comes and the follicles start forming and the follicles start producing E2, it will go and stop the pituitary from FSH secretion. And that's why we say that there are less chances of a hyperstimulation with the letrozole, because the central action ovulation is working. So monofollicular growth happens, while here the multiple follicles and chances of twin pregnancies are high with the clomiphene citrate. Now, how much dose and all that itself will become one lecture, which we are going to take subsequently on ovulation induction. I will be talking in detail about it. But remember, always starts in ethnic, obese patient, letrozole, India, we start 5 milligram. I start 5 milligram, while clomiphene, I always start with 100 milligram. Very rarely, I go with the very low dose. Letrozole used does not increase the risk of congenital anomalies. As I told you, it is the now Cochrane database also proven that letrozole improves the live birth and the pregnancy rate in anovulatory polycystic ovarian syndrome patient compared to clomiphene. Though they say the OHSS, they are probably maybe same, but no difference in a miscarriage rate and all, and letrozole can be used. What about the gonadotrophins? Now, oral ovulation, you give, when I'm going to take 1 hour on a stimulation, I'll be talking how many cycles and how to step up the doses, how we stimulate, how do we monitor, everything I'll cover that time. Today, it is a broad outline, and that's why I'm talking to you in a little brief. So letrozole is a first line of treatment. Gonadotrophin addition or ovarian drilling, this is a second line of treatment. So now when we talk about gonadotrophins and drilling, when to add the gonadotrophins and which gonadotrophins. So gonadotrophins for ovulation induction, one, when to add. Let me go to that question, when to add. When you have either letrozole resistance or failure, or clomiphene resistance or failure. It means alone clomiphene could not do ovulation, or that is called clomiphene resistance, or clomiphene failure means the ovulation happened, but still patient did not conceive. So you move on to add in gonadotrophins. Now, which gonadotrophins superior? So recombinant and urinary, both are equally effective. There is no difference between the urinary and recombinant. So you see the cost effectiveness. Now, what I do here with us, we have patients coming from metro city, transit becomes too much. Every day coming for a gonadotrophin injection of urinary becomes difficult. So I give them a recombinant FSH pen so that they can take the self-dose themselves. Second important thing about recombinant FSH using for me for practical purposes, smallest dose like 37.5 also I will be able to titrate. While with 75 ampule of a urinary, I may not be able to titrate the dose. So this is a second important. And that's why I may use recombinant for an IUI patient, but for IVF, if they are above 35, I use still HMG. Below 35, I may sometimes combine recombinant and HMG. The recommended starting dose is so low, and that's why I say the recombinant FSH, because it comes in a pen. Now, always remember, do you step up? These are what written in a book. 14 days, you give 37.5. Then after 14 days, you give 50. And then you step up 14 days. The cycle follicular phase can go to 70 days, 80 days. They have documented. But in my clinical practice, remember, 75 days, easy to say, 2.5 months. I keep on giving the patient one dose just to monitor one follicle. I don't think it is practically possible. And that's why in my clinical practice, if I'm doing a sonography, suppose on day 10, 37.5 dose is going on and the follicles are just 10, 11, 10, 11. I may, and if there are no more dominant follicles, only 2 follicles, I may jump to 50 immediately. If I see many follicles, I will not jump. Remember this, I'm not going to land up for OHSS for an IUI patient. But if I see only 2 follicles have gone, rest are all 2-5 mm. So they are androgenic follicle. They are not going to grow beyond. And here I see 2 follicles of 10 to 11 mm. I want both the follicles to boost up. because it's not the monofollicular I expect in IUI. I like to have 2 to 3 follicle. The evidence have proven that when you have a 2 to 3 follicles, your IUI success rate is higher than the monofollicle. We have to understand this. So in those patients, then I jump to 50 because I know she's not going to go for a OHSS. So it's very important that you need intense ovarian response monitoring to reduce the complication. You just can't decide gonadotrophins and ask them to keep on doing the sonography with sonologists. I have seen so many gynecologists, not only they tell the sonologist, but sonologist only decides whether to continue the dose or whether to stop the doses. Please, they are not the gynecologists. They don't understand PCOS. So it's very, very important that you do your own intense close monitoring. Am I supposed to use insulin sensitizer as an adjuvant? When you are using oral ovulation, they have found that clinical pregnancy rate and ovulation rate has improved with the metformin and clomiphene, but it did not got transmitted into the live birth rate. Remember, this is very important. But when it is the gonadotrophin they have used, and then they did a metformin, they found that there is also increase in the live birth. So when you are using oral ovulation, use metformin. I use it routinely. But always remember, the live birth rate probably is not different. With gonadotrophins, the live birth also increases, and we are allowed to use metformin as an evidence base. I'm not going to talk today about the luteal phase clomiphene citrate. We'll talk some other time. Now, second line therapy is either gonadotrophin or ovarian drilling. Now, when you would like to do the ovarian drilling, especially the young patients, good AMH, you have done 2-3 cycles, you did not got a success. You feel that there was a probe tenderness, you want to do the laparoscopy, otherwise also, then you do the laparoscopy. Remember rule of 4 punctures, 4 seconds with the 4 VAC. Now, why this is important? Because I have seen PCOS getting drilled so many times by everyone that by the time she reaches to the ART consultant, her AMH is below 2. She has become a poor responder. So please don't do that. Only once. And then you can allow the patient to continue her lifestyle modification, put her on metformin, and ask her to try 6 months. Probably she can conceive naturally because you have reduced the LH and you might have made her ovulatory. But keep a close watch. Don't tell her, go for 6 months now and try naturally. If it doesn't come back after 6 months, that doesn't happen. You need to monitor that she's losing weight, she's taking metformin, and you also need to see that for 2 months, if the menses have not come, it is not that it is because of the PCOS. Sometimes there may be a pregnancy and that poor lady will think that irregular cycle is her pattern. Then comes the third line therapy. So if your gonadotrophins failed or a laparoscopic drilling did not happen, then the third line therapy is IVF. I have seen so many patients, unfortunately, taking oral ovulation, 12 cycles, and then directly jumping to IVF. Both is wrong. Don't give the maximum success is in first 3 to 4 cycles. As the number of cycle increases, the success goes down. And go for a gonadotrophin, go for a laparoscopic drilling. Don't jump for a IVF because IVF also is not 100% success. If she fails IVF, then what? But sometimes in your mind, you know that interval to the pregnancy will be shorter with IVF. You can make her 15 embryos, freeze them. Even if you keep on transferring one in one cycle, definitely she is. So IVF is a sure shot therapy for a success in a PCOS patient. But that doesn't mean every lady needs this therapy. And in IVF, prevention of OHSS is very important. So by rule, antagonist therapy is the one you are supposed to do so that you can give LH as a trigger. Very important. So it is a Paul Deborah unit 1 decade ago came out with OHSS free clinic. Now, antagonist cycle is little expensive. So what we do for last 2 years, and we do have our own publication on a progesterone, you can write it, progesterone downregulation or progestin priming. So what we do in this patient is we don't give antagonist. On day 1 of the menses, I start their stimulation, and I also add on them with the norethistron, right? Dydrogesterone, norethistron. Devri. We are giving Devri. But I'm not supposed to say Devri. So norethistron, which will you check? So we give Devri 20 milligram. We have this publication, and I need to thank COVID pandemic, which allowed us the time, the number of cycles in the initial COVID pandemic phase. Medroxyprogesterone, sorry. It is a medroxyprogesterone. We start 10 milligram twice a day. Now, in initial period, we gave 30 milligram per day. Now, this medroxyprogesterone will not allow any interference, and you still can give a LH as a trigger. And now, our all cycles after COVID pandemic has given us time to see, treat, and there were fewer cases. So we could monitor them very closely. When you are doing 100 cycle, probably you want to go with the antagonist, because where is the time to see whether she ruptured, not ruptured. But when we had a time, we started with the medroxyprogesterone twice a day, and we could monitor this patient, and we realized neither we are getting premature LS surge, we are retrieving the eggs very well. The follicle to egg index is absolutely matching. The fertilization rate is not getting affected, neither the cleavage rate or the number of blastocyst formation. So we started, and now I don't know in last 1 year, any patient I have put on an antagonist cycle. We must have by now 500 plus cases in last 1 year with the progestin priming, and we got only in one case, we got the follicles, we got the eggs, but we had a lot of fluid in the pouch of Douglas. But sometimes when young patient, they get hyper-responded, you may have a lot of reactionary fluid in the pelvis. So it may not be rupture. Now, when do you start? First day. And when do you end? On the day of a trigger, you stop this. And that is how you make your clinic OHSS free. This is I was labeling to you as a Paul Deberoy's OHSS free clinic, which they discussed a decade ago nearly, and everyone started using because this antagonist protocol allows us. We all know that OHSS is because of SCG. Now, today, my also aim is to talk to you about the long-term treatment. I'm not blaming obstetrician. Patient also don't come. But when they deliver and they have one visit after 6 weeks, we ask them contraception. They said, what, ma'am, I have taken a treatment where I will conceive. And they don't bother to come for follow-up. The long-term consequences of PCOS get neglected. They may get period only twice in a year. They are not bothered. And that's why when the patient come at adolescent age, it's your duty to sit with them and talk about entire, from adolescent to reproductive to perimenopausal and postmenopausal. So what is the postmenopausal phenotype of PCOS, and how elevated should androgen level to be there? A diagnosis of PCOS in postmenopausal, you can consider if there is a past diagnosis of PCOS, long-term history of irregular cycle, features of hyperandrogenism, or you on a monitoring, you are seeing that picture during the reproductive age group. Then we call. But in a postmenopausal age group, you have to remember one thing: other causes of hyperandrogenism, especially the androgen secreting tumors or ovarian hypertrichosis, has to be ruled out. Okay. Now, what are the associated long-term risks? There are different paradigms we need to consider. Especially women with the metabolic PCOS subtypes are at increased risk of morbidity, the things that are not going to impact their quality of life. Sorry, uska niche ka likha nahi hai. So, They will have all the other problem, cardiovascular, diabetes, sleep apnea, and endometrial cancer. But friends, I'm going to tell you more than this, in especially these women have a higher risk of other morbidities also. This is an interesting study in June 2022, a population-based control group study for all in the Finland they did with all the age group of 46. And they gave them a questionnaires. And they found that the morbidity risk was 35% higher than women with the PCOS, without PCOS. So this is very high. In a common population, they did just the questionnaire study for all entire population, and 35% high risk of the morbidities. And the medication patient were maybe for blood pressure, maybe for diabetes, they were 27% higher incidence. And this is what I'm trying to tell you is, apart from, we always talk about diabetes, we talk about only hypertension, cardiovascular, or osteocarcinoma. Endometrial carcinoma. You have to think about, they may have more chances of osteoarthritis, migraine, tendinitis, and also endometriosis. They also can be associated with autoimmune diseases and recurrent upper respiratory tract infection. They have found this and this is very important. And this is slide I wanted to highlight, that you should be ensuring about autoimmune diseases, recurrent upper respiratory tract infections, and other things. So, friends, PCOS is a chronic medical condition and has links to the health condition independent of BMI. I have seen the patient who are obese, they may be worried. But the lean PCOS also should remember this. We all need to counsel that the BMI is not solely responsible for the increased morbidity. The average morbidity score of PCOS woman with the BMI 25 or higher was similar to that with the lower BMI. So BMI doesn't decide comorbidities of fourth and fifth decades of a life. All this is important: cardiovascular, blood pressure, hypertension, osteoarthritis, and so on. This is a beautiful photography. You imagine to get this beautiful, how much this lady has undergone injection. This is the first time I have been asked to do a photo like this, and I was honored and wanted to create. Look at this. She says, 4 years, 7 attempts, 3 miscarriages, and 1,616 shots. Can you believe this? So this is a problem of a PCOS, and we need to be all sympathetic. We should be giving them time, because it's not only for the fertility, not only for irregular menses, but even in the 4th, 5th decade of life, they can land up in serious problems. This morbidity will decrease their quality of life. The quantity as well as quality, both is important, and that's where you have to explain them. Friends, I always like to give credit to my assistants, my fellows, my residents who work equally hard with me, and that's why I can help my patients. Thank you so much.